and welcome to the Medi Classes postgraduate lecture series on acquired hypothyroidism. Over the last 2.5 years, we have been working on different modules related to pediatric endocrinology, and the PG lecture series has covered many like growth, calcium, electrolyte, along with thyroid and pubertal disorders. So we are going now towards acquired hypothyroidism. And acquired hypothyroidism is one condition which is quite common from a pediatric perspective and something which has significant implications in terms of short and long terms from different aspects, not just growth, but puberty, but many other issues. It can also be a cause of emergency, as was seen in this case. This was a 12-year-old boy who had presented to us with poor school performance. And at that point of time, he was found to have a low FT4 and a TSH of 9. At that point of time, the treating physician considered that this is a hypothyroidism. It's more likely to be a primary hypothyroidism because TSH is slightly high, and started on thyroxine. But within a couple of weeks, the child developed hemodynamic instability and shock. And what really went wrong here was that there was an erroneous assessment in terms of thyroid function. In that, when we remember that whenever the FT4 levels are low, we expect the TSH levels to be very high. If they are not high, this suggests a central hypothyroidism. So this was a central hypothyroidism with associated multiple pituitary hormone deficiency, which was missed and resulted in this abnormalities in terms of treatment. So clearly, this is one condition which is quite common, but often can cause a lot of confusion in that perspective. So this is a rare form of acquired hypothyroidism. We'll be discussing a lot about this in that regards. All of you can go and have a look at our website learning.growsociety.in, which has got multiple sources and resources regarding pediatric endocrinology, our e-learning platform, our courses which are there, along with our fellowship and pediatric endocrinology for postgraduate courses. We run a number of activities every month, including this PG lecture series, grand rounds, and journal clubs. And we have multiple publications ranging from pediatric endocrinology protocol to basic and advanced pediatric endocrinology. And our app provides comprehensive assessment of pediatric endocrine disorders, including thyroid interpreter, which is also available. So today we're going to focus about acquired hypothyroidism.
Thank you, sir. Good afternoon, everyone. So I'll start with the first case. A 5-year-old girl child presented.
Yeah.
Presented with short stature. You can see the growth chart of it. It is a actually boy. Sorry. So concerned about the short stature, and you can see the growth chart plotting the height and weight. The TTG is 32, and he was diagnosed as a case of celiac disease. So do you agree with this diagnosis, and how would you like to proceed in this case?
So what are the pattern of growth failure is what Dr. Alapan is talking about? Is it endocrine or nutritional? So you can just write on the Q&A. If not celiac, Dr. Ayesha has already mentioned. So do you agree, Alapan?
Yes, if you consider the height and weight, the height is affected much more considering to the weight. So probably this is a case of endocrine pattern of short stature. And if we further move into the investigation, we see the TSH level of more than 100 in this case. So this is a case of acquired hypothyroidism, which is misdiagnosed as celiac disease in the initial phase. And as sir always told that the better marker for diagnosis of nutritional versus pattern of short stature is a BMI SDS. Moving on to the next case, a 5-year-old girl child. She is concerned about weight gain for the last 1 year, and TSH level is 8.3. So she was advised thyroxine. She is an obese girl. So do you agree with advising thyroxine in this case?
So we can get the responses in the chat Q&A if you agree. So Dr. Neetu, Dr. Lana, Dr. Sajif, all of them are saying no. So yes, this is, I think, very, very clear message.
So basically the FT4 level is in the normal level, and TPO was negative. So basically this is an effect of obesity, not the cause. And anybody could explain the mechanism of this elevation of TSH level?
So which substance is increasing the level of TSH? So that is because of the
leptin effect on the
leptin effect in the TRH. So Dr. Parag is talking about leptin on TRH.
So moving on to the next case, a 8-year-old girl child presented with short stature and constipation and diagnosed as a case of acquired hypothyroidism, having a TSH level more than 100. So she was started on treatment with 75 microgram per day, and certainly he developed irritability, worsening of school performance, and headache. So treating physician has reassured her mother that this is normal and it happens with every child. Do you agree with this thing, or do you like to move further?
Which test should be done, which will give you a picture like that?
Simulated fundus.
So Dr. Ayesha has already mentioned fundoscopy to look for papilledema. So this could be a benign intracranial hypertension. So Dr. Ekta is also mentioning cortisol should be done, sodium level, papilledema. So papilledema is something which we should definitely
look for, especially
very important presentation.
Yes. So moving on to the next case, a 8-year-old girl child presented with short stature and constipation, having a TSH more than 100 and diagnosed as a case of acquired hypothyroidism. She was started on 25 microgram per day and presently on 150 microgram per day. Still, her TSH level was more than 80. So, what could be the possibilities of this high TSH level in this case?
So persistently high TSH despite a dose which is 3 times the expected limit. So Dr. Aisha has talked about celiac, Dr. Edley talked about compliance, celiac, malabsorption. So I think it's going in the, yeah, absolutely the same thing we're talking about. Dr. Anshika also, and malabsorption and drugs interference.
And some drugs may cause this kind of picture, which can interfere the thyroid function.
So we have discussed about
this thing, yes.
So that will be anti-epileptic
drugs, iron, calcium, and other agents. Moving on to the next case, a 5-year, 11 months old girl child concerned regarding the short stature, which is an endocrine pattern. TSH is 4, FT4 is low, 10 picomole per liter, and diagnosed as a central hypothyroidism. So she got started on 50 microgram of thyroxine per day, and suddenly 1 week later he presented to emergency with shock and uh, other features of dehydration. So what went wrong in this case and what should be done probably in this case?
So I think this is a case which is very important. We should have done cortisol, as Dr. Neetu is talking about. Dr. Parag also is mentioning the same scenario. Cortisol, ACTH, Dr. Arushi test for other pituitary hormones. Adrenal insufficiency is absolutely bang on. So I think this is one message which we want to give clearly, that if you have a low FT4 and a TSH less than 20, do not start treatment. Get a MRI done. Get a cortisol level done.
So moving on to the next case, this time an 8-year-old, 9-month-old girl child presented with short stature. Total T4 level was low and TSH was normal. So do you think this is a central hypothyroidism, or should look for any other test before confirming a central hypothyroidism?
So clearly we have got low T4 and TSH, but we need to know that most T4 is bound to TB. So we should look at that, I think.
So she was advised MRI, but the FT4 level was in this girl was normal. So before moving on to any other test, look for the free T4 level, whether it is low or not, before labeling someone as a central hypothyroidism. So moving on to the next case, 12 months old boy child admitted to ICU due to pneumonia, and the TSH level was low as well as the FT4 level, and she was again labeled as central hypothyroidism. So and advised thyroxine. So do you agree with this decision? And what is the test of choice here, which will differentiate between any other conditions present?
So in somebody who is admitted, very, very sick child, you find that the TSH is low and FT4 is low. So Dr. Arushi is mentioning cortisol. Yes, cortisol should be sky high. If it is non-thyroidal illness, it should be sky high. FT3, RT3, Dr. Aisha, yes, but that may take time, but better would be to do a cortisol, which will give you a much better picture. So both options are there. Do not treat unless the cortisol is low.
Yes. Moving on to the next case, a 7-year-old girl child presented with breast development and vaginal bleeding. As you can see, the SMS staging of this girl is B5M1 and the bone age is delayed 5.5 years. LH is low, FSH is in the normal range, and estradiol is 55 in this case. So what could be the next best test to diagnose this case, considering the context we are presenting?
So Dr. Anshika is mentioning FT4 TSH, Dr. Ekta TSH.
So this is clearly a case of von Wiesenbeck disease due to the TSH receptor. TSH acting on the FSH receptor. So moving on to the next case, a 12-year-old girl child presented with TSH of more than 100, SMR of B2, P1, and the bone age of 9 years, started on thyroxine, and after 1 year, she had developed the sexual maturity rating was B4, P2 with a bone age of 11.4 year. So how does this child should be managed from here?
So what are the options? We got limited time to grow. She was already pubertal and yet the bone age was less and it's increasing rapidly. So we need to do something to delay the bone age. And the option here would be, so JNRI channel of Dr. Neetu is talking about, yes, this could be a option. And this is something which we have used in some subset of patients with benefit, although there is not much randomized evidence. It will be very difficult to have randomized trial on this in that regards. So GnRH analog should be considered Dr. Aisha Zoladex. So yes, so all of them are absolutely right.
So moving on to the some fact check, I'll give you a statement. You have to tell whether it is right or wrong.
So you can say Y or N, yes or no.
Yes. So the first question, the half-life of levothyroxine is 7 days.
So this is out of course. This was not discussed here. But yes, who will like to hazard a guess? Dr. Parag is saying Y. People are waiting. Dr. Aisha is saying no. Dr. Arushi, yes. What do you think, Dr.?
Yes, sir, it is 7 days actually, 7 days.
So that's why it may have take time for TSH to stabilize. Yes, so it's 7 days.
Moving on to the next case, in Hashimoto thyroiditis, the thyroid gland is destroyed by the neutrophilic infiltration.
So do we agree with that? False, false, yes. So
It is lymphocytic,
not
neutrophilic.
again, yeah.
Moving on to the next, the DiO2, the MDI1 removes the iodine of T4 from the inner ring to make it T3. So I want to know whether it is an inner ring or outer ring.
So this again is a tricky question. So Dr. Ekta, you should know, people haven't responded yet. So we're talking about inner deiodinase or outer deiodinase. So what is your answer, Dr.?
So it is outer ring.
So this is outer ring. So this is more of a theoretical.
Yes. So the puffy edematous appearance of the autoimmune hypothyroidism is due to the accumulation of the hyaluronic acid. Any answers?
So is it because of hyaluronic acid? Is it because of fluid? Is it because of fat? So Dr. Ideally is saying false. So do you agree with that?
It is true. It is because of this myxomatous tissues.
So there are multiple factors there, but this is partly
yes. Moving on to the next question, the common site of dysgenesis of bone in hypothyroidism is the metaphysis.
So is it metaphysis, diaphysis, epiphysis? So Dr. Neetu says no.
Epiphyseal dysplasia.
So it is more of an epiphyseal
dysplasia,
not the metaphyseal. Metaphyseal is rickets.
Moving on to the next, the Wolff-Chaikoff effect is due to the inadequate iodine supplementation.
So yes or no?
So it can be moved here. This side.
So Wolff-Chaikoff effect is because of inadequate supplementation.
So
the answer is?
no, it is the excess iodine supplementation.
Yes. So excess causes suppression.
So moving on to the next, the hunger reflexes are due to the slowing of the relaxation phase of the reflex.
So again, relaxation or contraction, which one? So the answer is
it is the relaxation phase. True. Moving on to the next, the amiodarone prevents the conversion from T3 to T4 to T3.
So amiodarone we know can do anything. It causes thyrotoxicosis, it causes thyroiditis,
Yes.
it causes hypothyroidism. So the question is very specific, whether it prevents conversion of T4 to T3 or not. The answer is people have mentioned not yet. Yes, no. What do you agree? What do you say?
Yes, it prevents the conversion of T4 to T3. Moving on to the next, the hemangioma produces DiO2.
Okay, so there are three types of monodeiodinase, DIO 1, 2, 3. So one is produced in the
Non
normal
peripheral
tissue, two is in the brain,
brain.
three is in the peripheral tissue. So as Dr. Arushi said, it's mostly DIO3.
DiO3. Yes.
Yeah.
So the last question, the most common thyroid disorder is shown in Down syndrome is subclinical hypothyroidism.
In which we like to go, all of you to go and have a look at our website to look at different aspects of pediatric endocrinology, look at the books, the publication, the mobile apps, and we will join again in a couple of months with the subsequent aspect